make here is that this is a cartoon of the pancreas, and this gives you an idea of the 1% we're talking about. You see these tiny little dots? That's the way the so-called islets are kind of sprinkled throughout the pancreas. And this is a cartoon that describes how a typical islet looks. There are a bunch of different cells. I'll go into them in some detail. The green ones here are what we call the beta cells, which produce the famous insulin. But there are other red and blue cells that produce other hormones. And it is what happens with these cells that cause various hormone-related problems. And pretty much because of the way these islets are distributed throughout the pancreas, anything that affects the bulk of the pancreas can, just by what we call an innocent bystander effect, have consequences on the endocrine portion of the pancreas as well. So, like I said earlier, the endocrine part of the pancreas is what we call the islets of Langerhans. They are described in that way because they are almost like islands sitting within the sea of the exocrine pancreas. And there are at least 4 distinct cells within the islets. The alpha cells form about 15% of the mass of the islets and typically tend to be more centrally placed, and they produce glucagon. The beta cells form about 70 to 80% of the mass of the islets. They produce these 2 hormones, insulin and amylin. The delta cells are far smaller. They produce a hormone called somatostatin. And then there are these F cells that are between 1 to 3% and produce a hormone called pancreatic polypeptide. What pancreatic polypeptide does and its big role in the scheme of things is still the subject of considerable investigation. We don't know very much about it. But all these 3 are very well known. And they are so important that all 3 of them have been manipulated by the pharmaceutical industry and are available as treatments and medicines for various things. So let's talk a little about insulin, which is from the beta cell. Now, insulin is the one hormone that changed the nature of diabetes. Prior to insulin's identification in the early 1920s, diabetes was pretty much a diagnosis that was pretty much like many advanced cancers. It was a life sentence. You were told to get your house in order. There was little that could be done. But finding that these hormone is produced by the beta cell and being able to give it back to people has changed the nature of diabetes. And this cartoon just summarizes in a very elementary fashion the main things that insulin does. You should think of insulin as the hormone of abundance. Its goal is to sustain abundance of calories. It's the primary glucose lowering agent, but in addition, it is a growth factor. It's also an appetite stimulant and is the nutrient store hormone. So the greens are some of the things insulin does positively. It increases the uptake of glucose into the muscle. So it's what allows you to be able to utilize the energy that you get from your calories. It enables the breakdown of glucose to release energy, glycolysis. It enables you to store some of that energy for the rainy day, glycogen synthesis. It enables you to form proteins to help build your muscle mass, and it enables you to take up certain chemicals. Now, these may seem like minor things, but when any of these goes off, any of these goes wrong, it can have profound impact on people's capacity to function adequately. And then the reds are the things that it stops. So again, it's the hormone of abundance. So it essentially stops all those things that happen when you are wasting, when you don't have enough calories, you don't have enough energy. It kind of limits them. Now, there is way more complexity to insulin than this. There are so many different types. It's long-acting, short-acting, there are different ways to deliver it. But just to get some idea of what this hormone from the 1% of the pancreas does, gives you some perspective of why that 1% is so important. Then let's talk about glucagon. Glucagon comes from the alpha cells. These are some of its major actions, and like I said, for 3 out of these 4 hormones, they are all commercially available for various reasons. The most common setting in which people get exposed to glucagon is as your, almost like the EpiPen for people with diabetes. You use it to treat episodes where the blood sugar drops very low, because it's almost like the yang to insulin's yin. And some of the things it does, in contrast to insulin, is acting on the liver, and all these items I've listed here, increasing glycogen breakdown, reducing glycogen synthesis, increasing new glucose production, increasing ketones. All it does is to raise the blood glucose, to provide the calories to deal with the low blood sugar reaction. And so glucagon is commonly used as a treatment for acute episodes where the blood sugar drops. But there is more to glucagon than that, and as pumps continue to develop, what is coming around the horizon shortly, because that's what happens naturally, is to actually use glucagon as a co-hormone. There are already several trials that have been done successfully, and we anticipate, certainly I anticipate, that within our lifetimes, we will be at a point where people who are insulin dependent will be getting not just insulin through their pumps, they'll be getting insulin with glucagon modulated through their pumps, so that you have better balance. Somatostatin, not very commonly known for those who haven't had problems related to it, but this is colloquially called the negative hormone. Just think of this hormone as the brakes within the system. It is capable of reducing the production of all the other hormones and also all the other enzymes from the pancreas and many other parts of the body. So this long list here, virtually everything it does to differing degrees is to reduce the amount of production of hormones and or enzymes. So it's like the brake within the system. And its production is very carefully regulated. Problems arise with somatostatin if and when there is overproduction. As you can imagine, the consequences can be quite severe when you have overproduction of this hormone. But the pharmaceutical industry has also co-opted this hormone to help treat patients who have excess hormone production states. So we use this to treat people who have unusual pituitary tumors, for instance, and in people who have problems in their liver with overproduction, hepatic pressure problems, somatostatin can be used to reduce the production of hormones, reduce the production of abnormal hormones. And then there's amylin. Amylin is the second hormone produced from the beta cell along with insulin. It's the junior partner hormone, and its major mission is to keep blood glucose well regulated, while insulin's way of doing that is to essentially store all the nutrients away. Amylin's major way of doing that is limit the intake of nutrients in the first place. So it would reduce the speed at which the bowels take calories to the intestines. It would reduce the production of other hormones that would cause glucose levels to rise, and it works in partnership with insulin to keep blood glucose controlled. So these are some of the things that amylin does: slows gastric emptying, reduces glucagon release, has a negative effect on the alpha cells. And so by doing that, along with insulin, it ultimately reduces plasma glucose. And again, like all the others, amylin is available for use therapeutically in patients with type 1 diabetes and also in type 2 diabetes. Amylin can be given as a partner hormone to optimize glucose control. So let's shift to some of the diseases of the pancreas. A lot has been said already about pancreatitis, inflammation, acute and chronic pancreatitis. I will say a few words about cystic fibrosis a little later. It's also important to remember, even though they are not common, beyond duct problems, some patients have abnormal accumulation of pancreatic tissue in other parts of the body. There are some unfortunate patients who have either reduced pancreatic mass or no pancreas at all. And then the endocrine problems of the pancreas we've hinted about, diabetes and islet cell tumors. So what about type 1 diabetes? The classic presentation is that this tends to be typically abrupt in onset. It's the result of autoimmunity that attacks those beta cells. So this is the way a normal islet looks. This is what we call insulitis. You see that it's denser, there are a whole bunch of cells in there, inflammatory cells, and that progresses to this and ultimately to total destruction. So you have this 1% of cells, 1% of the pancreas that are the beta cell and that are the islets, 80 to 90% of them beta cells. And if you have anything that causes inflammation of these group of cells, it slowly destroys the capacity to produce insulin. Invariably and eventually, people who have this become insulin dependent. Typically childhood onset, but that's not invariable. We now know that it's a spectrum. There are patients who have something called latent autoimmune diabetes of aging who develop very similar presentation but later in life. And the complications of type 1 diabetes include what we call microangiopathy, small vessel disease. And that's why people who have type 1 diabetes for a long period of time have kidney, nerve, eye problems. And then macroangiopathy, large vessel disease, problems with the blood vessels that supply the heart, the brain, and the peripheral arteries. Type 2, on the other hand, is the commonest form of diabetes that there is. Its onset is more gradual and slow, and it's often, because of that, taken less seriously. The typical type 1 patient can pretty much tell you almost to the day when they found out, because it's fairly abrupt. Here, it just kind of wanders along, and it is easy, if one is not vigilant, for people to have this diagnosis for years. And unfortunately, that doesn't mean it's innocent. It is busy doing damage while silent. The end stage of this condition is what we call amyloid accumulation in the pancreas. So this is how it looks. The pancreas, the islet doesn't look anything like a normal islet. It's just full of scarring and this abnormal protein called amyloid. Most people with type 2 diabetes can be managed by various means. It's only in advanced stages that they become entirely insulin dependent. And by that time, the damage in the islets is so extensive that it starts to look, for all intents and purposes, like people with type 1. The complications, macro and microangiopathic disease, are very similar, but the relative preponderance is inverted. So with your type 1 diabetes, small vessel disease is what starts out, and large vessel disease tends to develop later on in life. With type 2, the large vessel disease is usually early onset, and it's probably there by the time you see the patients. And the microangiopathic disease comes later, depending on degree of control. Now, we talk about type 1 and type 2, but it is important to be aware that those distinctions have started to blur. It's not black and white, it's more like gray. There are a lot of hybrid variants of diabetes. Some of you may have heard of so-called type 1.5, type 3. There are many different layers and flavors of diabetes. But when it's all said and done, diabetes does translate to something has gone wrong with those beta cells in the pancreas. Either they are not functioning okay, there's resistance to the action of the insulin they are producing, or a bit of both. I don't think I will spend a lot of time on pancreatitis. We've already had a lot about it, except to mention that because of the nature of pancreatitis and the inflammation that it causes, the inflammation doesn't respect borders. It will spill out, it will spill over into surrounding tissues, and that tends to be how diabetes eventually develops in this condition, usually in the setting of chronic pancreatitis. If you have just one episode of acute pancreatitis, chances are that you will have enough of your beta cells preserved and you shouldn't have any issues. But keep having those episodes recurrent, so-called acute relapsing pancreatitis, and you end up with chronic pancreatitis. By the time you have the scarring and the stones and the pseudocysts and so on, by that time, it would have taken a toll on the beta cells. And so diabetes in the setting of pancreatitis is the result of this so-called innocent bystander effect. Because the beta cells are there, they are in close proximity, they get damaged, and eventually diabetes develops. Now, what about cystic fibrosis? Because it's one example of how this can happen. And in the setting of development and evaluation of people who present fairly young with diabetes, screening for cystic fibrosis is really very important. It's pretty common. 1 in 3,000 live births, 1 in 25 carriers. And so this is one situation where, because of the genetic mutation, there is abnormal production of electrolytes from the ducts, and the pancreatic secretions are more viscid than they ought to be, and so there's greater chance of having blockages. And in the course of having the chronic inflammation, so this here, the pancreas, you have production of cysts, that's where the cystic comes from. There's blockages caused from viscid mucus, and eventually it causes destruction of the exocrine tissue and the islets. Long before patients become entirely insulin dependent, many of these patients will already have evidence of a degree of diabetes. So cystic fibrosis tends to be associated with a form of diabetes that is somewhere in between your classic type 1 and classic type 2. Many of them will need some insulin because their insulin production is probably inadequate, but it doesn't tend to be to the degree in type 1s. Many of them tend to end up managed using certain medications we typically use for type 2 and other, with some insulin added on. So that's one of the conditions that highlights this innocent bystander phenomenon. Another one where there's a relationship between genetics and this innocent bystander phenomenon is hemochromatosis, which is touted as the most common genetic disease in people of North European origin. And here it's a mutation of the genes that control iron absorption and iron, the so-called mucosal block. There's excessive iron absorption from the bowels, and iron in excess is a toxin. It will eventually cause damage in the brain, in the pituitary, hypopituitarism. It will cause damage in the liver, cirrhosis, and the possibility of hepatic cancer, cause damage in the heart, and of course it causes damage in the pancreas as well. And that's how the diabetes develops. Now, because of the accumulation of the pigments that can happen in the skin, you can see this contrast here, and hemochromatosis is the cause of the so-called bronze diabetes. When someone finds that their complexion has started to change, they're just getting darker, in addition to the development of diabetes. That's a thought that needs to come to mind, and it's out there. It is far more common than people give it credit for. And then a word about pancreatic cancer, which has been mentioned already. Because of where the pancreas is located, it's retroperitoneal. And this is an area obviously where there's a controversy, there are issues about how should we be screening. But the point is, because of the location of the pancreas, it's not uncommon that by the time pancreatic cancer is found, it is often quite advanced. And the things that should make one a little more concerned, and Jim was talking about being an advocate. You as the patient yourself, or advocating for your loved one or your child, if there are any of these risk factors, these are some of the risk factors for pancreatic cancer. But if one has these genetic predispositions, whether it's the spin gene, whether it is whether it's the CFTR mutation, the HFE mutation, all those put the patient at higher risk of having recurrent pancreatic inflammation. Given enough time, the potential for cancer is there. And the problem is many of the clinical symptoms that would indicate cancer, by the time they develop, the cancer is well advanced. So the cancer would be, if there are factors in your history that increase risk for that, you will need to be proactive, because at least as of now, there are no clear guidelines as to what we should be doing. The other point to make is typically for type 1, type 2 diabetes, we have normal typical ages of onset. Someone who is older, and I'm saying 55 or older, who develops new onset diabetes needs to be screened for pancreatic cancer. It is an unusual time for someone to be developing cancer and to be developing diabetes, and there is an association. It's not great, but it is there, between diabetes as a condition and pancreatic cancer. So let's talk a little bit about other types of tumors that are not cancer necessarily. We call them the islet cell tumors. So remember what we said about the islets and the different cells? Well, it is quite possible for each of these cells to develop abnormal growths as well. Most of the time they are benign, but there is the possibility also of islet cell cancers. They are quite rare. As it turns out, the Ochsner Center here is a regional area of expertise where they see these sort of patients. So the most common of these islet cell tumors, as you can imagine, because they have the largest mass of cells, are the insulin-producing ones. These are the insulinomas. So these are the patients who produce excessive amounts of insulin, which does not obey the normal boundaries. And so these are the patients who would have recurrent episodes of hypoglycemia. The sugar just drops. It is almost like narcolepsy of glucose. The sugar drops without any warning. These are people whose sugars can drop to really dangerous levels. And if someone keeps having that, especially if it happens at night, so this is not a little different from the lows that can happen following meals. Someone keeps having lows, waking up totally drenched in sweat. A thought needs to be made about this possibility. And the testing is fairly difficult. You pretty much have to catch the patient in the act, catch them when the sugar is low. And when you do the appropriate testing in that setting, it is fairly clear what's going on. And that is important because most of these tumors are very small. We are talking, most of them are less than a centimeter. It then becomes a detective business to try and find out where it is. Glucagonomas are the same sort of situation, but from the alpha cells that produce glucagon. And as you can imagine, because it's an anti-insulin hormone, patients who have this will develop a unusual form of diabetes. They often have an unusual rash as well, that many times can be mixed up for other things. There are patients who have thought they've had psoriasis, for instance, and yet this is what they have. Somatostatinomas are rarer still, and these are the patients who have tumors that produce somatostatin. And then there are even other ones, carcinoids, gastrinomas, etc. There's this condition of nesidioblastosis, where it's not so much one tumor, but a whole bunch of tumors, a whole bunch of overgrowth of the islet cells. Most of the time that is some children are born with that, but it's the same situation, except that it's not one tumor. Many of the islet cells are just overactive. And this sort of patients will present with major hypoglycemia. One unique scenario where this happens is in a group of patients who've had bariatric surgery. So obviously bariatric surgery is being done way more now. Particularly patients who had Roux-en-Ys in the older age, when they had wider limbs. Some of them develop this condition. And if that happens, they will have to see a specialist who may look into possibly reversing the Roux-en-Y to try and help them deal with the hypoglycemia they're having. MEN1 is an important predisposition to all this group of syndromes. So people who come from a family who have an MEN1 mutation, they need to have any and all of these possibilities on the radar. So let me round up by going over some broad principles for pancreatitis. You've already heard about avoiding the precipitants of pancreatitis. For chronic pancreatitis, pain control, enzyme replacement. For diabetes, lifestyle modifications. Invariably, for people who develop diabetes, it often requires that lifestyle will have to change. Diet, exercise, it pervades everything. Weight management, appropriate use of medications, insulin replacement. There is a role and a place for pancreas or islet transplants. That's a decision that will have to be made on a case-by-case basis. For the hypoglycemic syndromes, making the correct diagnosis is important, and that requires a high index of suspicion. Many times, people are having recurrent hypoglycemia can mix up for a whole bunch of things. It's unfortunate, but it is possible and often happens that they are put off as having a psychiatric syndrome, they are put off as being hypochondriac. One thing that will help, unfortunately now, glucometers are very common. If you think you or loved one has this, you need to get yourself a glucometer, you need to start tracking this stuff. And if you find that when you're having these episodes, your blood sugars are under 70, document and journal it, and then go see someone. Because hypoglycemia is trouble waiting to happen when you work with machinery, when you drive. All sorts of bad things can happen in that situation. Now, for cancers and tumors as a whole, early detection is key. So appropriate screening in high-risk people, early commencement of chemotherapy, radiation treatment, surgical removal, and in some of these conditions, hormone-based treatments. This is important, and Jane's story highlights that. These are complex conditions. It is very difficult for one caregiver, medical caregiver, to cover all the bases. It's in your best interest to get a forest around the patient who's seeking care. That you have someone looking at the exocrine pancreas, someone looking at the endocrine pancreas. Your primary care is on board. Other members of the health team. And it may require you to coordinate and set that up. And then I cannot emphasize how important it is to have the support structure. This sort of forum is really important so that you have resources that you can reach out to, and getting other members of the family, nursing staff, and so on, so that you are not carrying all the load yourself. So these are my concluding remarks. Remember, the pancreas is 2 organ tissues in one. Don't forget the 1%. Enzyme producing exocrine pancreas, yes, that's 99%, it's important, but that 1% that produces hormones is just as important for health and normal pancreas function. Disease of the pancreas, we've gone through very quickly. The endocrine pancreas can present with a wide spectrum of various conditions, ranging from diabetes to various forms of hypoglycemia. And just to paraphrase, of the endocrine pancreas, it can truly be said, never has so much been owed by so many to so few. The 1% should never be taken for granted. And that's it.
Questions from anyone? Anybody have any questions?